Yes, Sriyashi.
Yeah. So, good afternoon and a warm welcome to all the dignitaries present here. I'm Sreushi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat, and the focus of today's session is POCUS Series 26 basic views in neonatal lung ultrasound. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir.
Yeah. Thank you so much, Sriyashi. So, today we are continuing with our neonatal focus series, that is number 26. We continue with our focus series on every Wednesday between 3 to 4 p.m. And as previously I've also talked with everyone, we have started the neonatal nursing Pathshala series in Gujarati language for all the nurses in. So I request all to join for that also. So today we are lucky to have Dr. Surjit Madan Madam with us. She is started her own course on lung ultrasound, and it is a very interesting course also. So thank you so much, ma'am, for coming to our Neonatal Pathshala platform and sharing your knowledge with us about the lung ultrasound. It is a very upcoming and interesting thing that mainly it is more of a study of an artifact rather than the images which we get, and it would be a very interesting thing to learn. And we'll be on the YouTube live, and the lecture will be there on our Neonatal Pathshala Gujarat NNF website, YouTube channel also. To share about Surjit Madam. She has done her fellowship in neonatology, and presently she is a senior consultant neonatologist and director at PMG Children Hospital, Jalandhar, Punjab. She is a certified in neonatal POCUS. She is a national international faculty and a speaker in POCUS and a national trainer for NRP India also. Thank you so much, ma'am. We are lucky to have you on this platform of Neonatal Pathshala. Over to you, madam.
Yeah. Before starting our today's session, I would like to thank Gujarat NNF and Dr. Nirmal, Dr. Kunal, Dr. Mohit Sani for inviting me to deliver this lecture. It is always a pleasure to be associated with the NNF Gujarat. And to me, Gujaratis are really like good. They have very good hospitality and really very warm and kind. So it's always a pleasure, Dr. Kunal, to be there with you all. So, uh, and yes, as Dr. Kunal told, we have a 3 months extensive lung ultrasound course also. So this will be just a stimulation on how we look into the lungs by our scan machine in our neonates. So we'll start with it. Yeah. So today we'll just go through a bit of basics of lung ultrasound in neonates. Like the aim of we'll try to cover the indications of lung ultrasound and the normal lung ultrasound nomenclatures. What are the techniques to do lung ultrasound in neonates? And we look into the common artifacts and the terminologies. The main aim of today's session is to stimulate you all and help you learn some standardized nomenclatures and terminologies so that when we all do lung ultrasound, we have some common way of doing it and there is some standardized terminologies which we all over India and abroad can use it in a same way, so that there are no confusions. Like we all can discuss how in a uniform way, in a consistent manner, and kind of we all understand. Like in case I tell some nomenclature in lung ultrasound, so everyone should understand what I am actually trying to explain. So the aim of the today's lecture is actually to stimulate and initiate the normal lung ultrasound basics in the doctors who are like beginners for this. So in the last so many years, like we have been using our stethoscope, right, as an extension of our sense in terms of listening and trying to figure out the chest pathologies we are dealing in our NICU. Now it's a time of lung ultrasound to diagnose our lung pathologies. So in near future, I'm not very sure if we are going to completely replace stethoscope, but we're going to be this insonation is going to be a fifth pillar, like after inspection, palpation, percussion, auscultation. After this stethoscope, this is definitely going to be a part in our bedside clinical examination. Yes, I'm not very sure if it will actually replace, but in my center, when I'm like actually doing my NICU rounds, I'm actually carrying the machine, so it is very helpful during the NICU rounds to see actually what pathology we are dealing in our sick neonates. So as we all agree, lung disease is the most common cause of neonatal respiratory distress, right, which we come across in our NICUs. And it is one of the most common cause of death in severe cases. So as we all know, clinical science, chest X-ray has low sensitivity and specificity. So now it's a time of lung ultrasound to overcome these chest X-rays. Like we have been using chest X-ray for the last decades, right? And we have been doing fine. We all must be thinking, why do we actually need to learn lung ultrasound? We were like very happy with the chest X-rays. But I think it is already an awareness is being created that how helpful and how sensitive is a lung ultrasound. So, in terms of sensitivity and specificity of lung ultrasound over chest X-ray, lung ultrasound actually overranks the chest X-ray. So it is not only me who is talking, but it is actually superior in diagnosing many lung pathologies like TTNB, RDS, and all. Look at this. Look at this sensitivity and specificity pattern in pleural effusion, in consolidation, in interstitial syndromes, in pneumothorax. It is actually seen that lung ultrasound has a sensitivity and specificity of around 90 to 100%. So it gives us more information regarding the pathologies we are going across in our neonates. Not really at this time. We are like, I'm not sure if it will replace chest X-ray, but yes, we all are learning, all our fellows are learning lung ultrasounds. Maybe in in due time, like definitely, lung ultrasound is actually going to help us um, in diagnosing lung pathologies. So to just start with the little of basics, like we know that we have different medias in our body, like we have air, we have bone, fluid, and soft tissues. So what happens in lung ultrasound? We are actually not seeing the exact organ. Like there are different organs in a body, like there's heart, there is spleen, there is liver, there is kidney. But in a traditional medical sonography, what happened? We actually study the segments and the organs of the human body. Till now, we were doing scanning of these organs which were devoid of air and bones, such as heart and kidney and liver and all. But why we always thought that the organs which are filled with air, like or there are bones in lungs, there is a rib cage, there is air in the lungs. We always thought that um, we cannot do a scanning of lungs. Initially, it was used for thoracocentosis and for the diagnostic and therapeutic for the pleural effusion and all, for the pneumothorax and all. But of late, what has been done that some artifacts which have been formed by the air which is there in the lung, we have started analyzing and interpreting those artifacts. Like whenever you see in the lungs, you have bone and then you have a soft tissue, or you have air and then you have tough soft tissue. So you have these interfaces in your lung, and because the density of bone is very high. So what happens when the ultrasonic waves come and hit the bone? Bone is a bad conductor of for the ultrasonic waves, and it reflects back all the sound waves. And that is why we had thought that we cannot do a scan of lungs. But because of these interfaces, whenever there is difference in the interfaces, or like bone and soft tissue density is quite different, air and soft tissue density is quite different. So this, what happens when these interfaces are there, when the sound waves come across, it reflects, it creates some energy which goes back to the machine, to the transducer, and few artifacts are formed and then they are analyzed. So what happens? Ultrasonic beams actually cannot penetrate the air, but they get reflected back because air and bones are the bad conductors, and some energy which are called as some patterns are formed on the machine which are called as artifacts, and these artifacts are displayed on the machine, and then we actually see the interpret these artifacts, and then we associate them with a certain pathologies. So what happened till 1990s? We always thought that lung ultrasound cannot be done because of the air. Air is there in this lung. So then, what happened? Daniel Lichinson, who is the father of lung ultrasound, he in the late 1990s, Daniel Lichinson, who is often referred as a father of lung ultrasound, he published a landmark paper describing the interpretation of the lung ultrasound artifacts to detect the lung pathology. So after his work actually dramatically transformed the diagnostic and the therapeutic landscape of the lung ultrasound. So after 1990s, like more of we have started doing lung ultrasound, and then in different pathologies and in critical care, it is actually being used extensively nowadays. So we'll learn what are the indications, what are the probe used, what is the procedure, what is the technique of doing lung ultrasound, what is the mode, and what is the sequence of examination, and how a normal lung looks. So the lung ultrasound is a need of hour because chest X-ray, as we know, is very time consuming, needs transportation, and we always thought that nothing else was there other than chest X-ray. So we kept on doing X-rays, but now, as we know, we have lung ultrasound, and also the chest X-ray has low sensitivity, specificity, and we are exposing the babies to the radiation. Right. So what are the indications? There are diagnostic and therapeutic applications of lung ultrasound. Any baby coming to your NICU who is having difficulty in breathing, or there is cyanosis or grunting, apnea, in any way there is difficulty in breathing, or there is sudden deterioration of any baby in your ICU, or you want to do some lung scoring for RDS, for BPD, you can do lung ultrasound. If you want to give surfactant administration, and then you want to see how is the response to your surfactant, how well your lungs have started aerating, or for other pathologies like pneumothorax, for pneumonias, for atelectasis, for pleural effusions, in pulmonary edema or interstitial syndromes, it is lung ultrasound helps. So in the recovery, you can actually do the scanning of diaphragm to assess how the diaphragm is working in a baby who is on ventilator, or you can also detect pneumonias, and you can actually do the ultrasound guided bronchoalveolar lavage a test, and you can actually do thoracocentesis, and you can see what is the progress of the disease, how is the response to your treatment. And nowadays lung ultrasound is done before extubation to see how well the lungs are recruited, whether your baby is ready for extubation. So if your baby has lung edema, you can plan for it will help us to guide the for the diuretic use. So, um, also the advantage of lung ultrasound is there are certain limitations of lung ultrasound, like it is operator dependent. You actually have to learn. So that is why we are doing so many workshops and so many sessions on lung ultrasound, which will stimulate you and help you get the knowledge of lung ultrasound, and you have to actually learn the skill of doing it. It takes around 4 to 6 weeks of training for that. And there are certain limitations that subcutaneous emphysema sometimes hinders the sound waves, or it is difficult to diagnose the emphysemas. So the advantages of lung ultrasound is that it is a dynamic technique. You can actually see the what changes are happening in the lungs of your baby in the real time. It is a very quick procedure, like you can do within 2 to 3 minutes. It's a bedside modality. There's no radiation. You can do that multiple times. You can do lung ultrasound multiple times in a day or in a week. And also the neonates have a thinner thoracic wall. So, and the sensitivity of specificity of lung ultrasound is really high. It helps in therapeutic and thoracocentesis, fluid management, as I've already told. The most biggest advantage is that you, as a neonatologist, you yourself are performing and interpreting your scans, and so that you can actually correlate with the clinical course of the baby. So there are techniques. Let's see what are the techniques to do scan. And the probe which we use commonly is a linear probe, or a curvilinear probe can be used. For the neonates, you can use a high frequency probe. So if you think the weight is more, or the baby's chest is thicker, so you can use a little lower frequency probe. Otherwise, in a preterm or in your usual neonates, you can use a high frequency probe. If you have an extreme preterm, you can increase the frequency of your probe, because the more the frequency, the better will be resolution. And your neonate, you want a better resolution, better clear picture for your scan. The penetration is not an issue, because the anterior posterior thickness of your neonate is less, the chest is thinner. So penetration is not an issue. We need a better resolution. So use a high frequency probe, maybe 7 to 10 megahertz or 6 to 12 megahertz usually helps. But before using the probe, you have to disinfect the probe, so that you prevent the nosocomial and cross contamination. Now we have hockey stick probes also, which have a small footprint for your extremely low birth weight and extreme preterm babies. The advantage of hockey stick is that it has high frequency, more than 15 megahertz. It has better resolution. So when you are handling your probe, put a warm gel on that before you start, so that apply a good layer of gel on the transducer, so that you make sure that there are no air bubbles in between the transducer and the skin surface. So you have to prepare your baby, right? Before doing a scan, you have to look at certain things, like the baby should be in a quiet position, not crying. A baby is not moving. So you can like soothe your baby with some sucrose, or you can feed the baby before you do the scan. So usually a sedation is not required for doing lung ultrasound. And you have to keep the baby in supine position. Ideally, yes, you can do in prone position also. Once you want to change the position of the baby, wait for 60 minutes and then do the scan, because in the dependent areas, there will be more of gravity will pull the fluid to the dependent areas. So you have to take care that the temperature of the baby is maintained before during doing the scans. If you feel the baby needs oxygen, you can give oxygen to the baby so that it withholds the procedure well. And the duration has to be short. Try to do is as quick as possible. I think I can do it in 1 minute. You try to finish it off in 2 to 4 minutes. So the best position to do is in a quiet supine position. Sometimes side or prone position can also be kept. And there are two ways of keeping the probe. Just look at this picture carefully. This is an hockey stick probe. So this is a actually there is assumed in hockey stick probe here it is the tip is taken it as a probe marker. Otherwise, if you have a linear probe, you have a marker, right? On the probe, you have a probe marker. So the probe marker always has to be kept cranially, and the probe has to be kept perpendicular to the chest wall. You need not tilt the probe. It has to be exactly perpendicular to the chest wall in this way. So this way of keeping the scan is called as longitudinal scan. And ideally, we do a longitudinal scan. But sometimes when you want to do an extensive lung ultrasound, you want to look into each of the intercostal space. So you can keep the your probe horizontally in between the intercostal spaces. So this is called as horizontal scan, horizontal or transcostal scan. So we have two techniques of doing. One is a 6 region technique, um, another is a 6 region technique. So we'll divide the chest anterior, lateral, and the posterior chest wall into 12 regions. Just look at this first picture. This is the anterior chest wall. And this one vertical line is drawn at the sternum, and the horizontal line is drawn at the mammary line. In this way, you divide the anterior chest wall into right and left region. And again, each of the anterior region is divided into upper and lower, or superior or inferior region, right? So you call this right anterior superior as R1 and right anterior inferior as R2. In the similar way, on the left side, we have L1 and L2 regions. So we have 4 regions on the anterior wall, anterior chest wall, and this is a lateral area of the baby. Right, I will mark this for you. All right. So this is one. Right. So this is a lateral region. So it is the lateral area is is divided anteriorly by the anterior axillary line, posterior by the posterior axillary line, and the mammary line divides the lateral area into superior and the inferior area. So this is L3 and L4. Similarly, on the right side, you have R3 and R4. So this is the posterior. This is the posterior chest wall. We divide, there's a vertical line which is at the spine, and there is a horizontal line at the lower angle of the scapula. Right. So in this way, the posterior wall is divided into left posterior superior is L5, left posterior inferior is L6. Similar way, L5, R5, and R6. Right. So this way, we divide the regions into 12, chest wall into 12 regions. There's another technique of doing scan lung. So this is a 6 region technique. Right. So this is again anterior area, lateral. This is anterior. Sorry, this is anterior, lateral, and the posterior area on the right side and left side. But the difference is that it is not divided into superior and the inferior region. So on the right side, you have 3 regions, and on the left side, you have 3 regions. This is called as 6 region technique. So usually we do lung ultrasound in a 2D or grayscale, and sometimes M mode is done for seeing the moving interfaces. We'll go through it. So you have to keep your probe perpendicular. Right? Keep your probe perpendicular to the chest. Adjust the gain depending on the clarity. It should neither be too white or no, too dark. The depth has to be adjusted. It has to be kept 3 to 5 centimeters. And the probe marker, as I showed, has to be kept cranially. And you should not tilt the probe. The position of the probe has to be very appropriate. Right, so let's see what is a quick about the anatomy of the superficial chest wall structures in the lung. We have a skin, subcutaneous tissue. We have the pectoralis muscle, and these are the ribs, right? These are the ribs, and in between the ribs, we have the intercostal muscles. And this line is the pleura. You have a parietal pleura and a visceral pleura, and below that is a lung parenchyma. So let's see how this looks in the 2D image. So just a comparison with the anatomical image and the 2D image of the scan. You have, this is the skin, subcutaneous tissue. You have pectoralis muscle. This is the rib, right? This circular oval thing is a rib, and in between the ribs you have intercostal muscles. And the area below the rib is black. I will show you why it is black. And this is a lung parenchyma. So today we'll see what things you have to see in the normal lung. We will see how to look into pleural line, A lines, what is batwing sign, what is lung sliding, what is seashore sign, and the diaphragm movements will not be covered in the basic. So the batwing sign, just concentrate on this part. This is this echogenic horizontal line is a pleura. This is taken as a considered as a body of the bat, and these two ribs beside that are taken as a wings of the bat. So this is an imaginary picture of a bat. So this is a bat wing sign is normally seen in a normal lung this way. This is C. This is a pleura and these are the ribs. So this is a batwing sign. So as I told you, these two are the ribs. So as the ultrasonic waves do not penetrate into the bones and they reflect back, as the bone is a bad conductor of ultrasonic waves. So you see nothing below the ribs. So this area is a black area, which is called as acoustic shadow. This is again normal in a lung scan. Seen as in a normal lung ultrasound. So this is how a normal lung ultrasound looks. The skin, subcutaneous tissue, pectoralis muscle. These are the ribs. In between are the intercostal muscles. This is a pleural line, horizontal echogenic pleural line. We'll go into detail. And these are few artifacts which are seen. So first, let's see how pleural line looks. This is a lung ultrasound. So just concentrate on this hyperechogenic line, which is a horizontal, thin, smooth, regular hyperechogenic line, and the thickness is less than 0.5 mm. This always indicates a parietal pleura. This is actually formed by the echo-reflection of the pleural lung surface interfaces. So this pleural line normally moves to and fro, synchronizing with the respiration. This is called as lung sliding. So what is lung sliding? When there is a visceral and the parietal pleura, they slide over each other. So this sliding is called as a lung sliding. This will create a shimmery kind of ant marching appearance. It is seen in a healthy lung. I'll show you how it looks. So the lung sliding is it actually defines that the alveolar air is within the visual field, and it indicates a normal neonatal lung in an area scan. So it's a sign of a normal healthy lung, the good pleural sliding or lung sliding. If there is absence of lung sliding, means there is some pathology. So look at this video. These are the ribs. This is a bat wing sign, and this is a pleural line. Look, this is a smooth, continuous, echogenic, white, horizontal line, right? And you can appreciate some ant marching within the pleural line. This is called as lung sliding or pleural sliding. This is seen in a normal, healthy lung. With time, as you keep doing lung ultrasound, you will get more expertise in appreciating lung sliding. So sometimes the lung sliding can be absent in cases like commonly seen in pneumothorax, but it can also be absent in pleural effusion, in pneumonia, severe pneumonias, ARDS, pleurodesis, or in pneumonectomies. So just coming to few artifacts. Once we have learned the pleural line, we have seen what is a lung sliding. Now coming to the A lines. A stands for air, and I'm very happy when you have good A lines with a good pleural sliding. So I call A lines are awesome lines. So I'll just show you. See, this is a pleural sliding with pleural line which we just saw. So there are some horizontal lines, echogenic lines which are parallel to the pleural line, right? This parallel lines, horizontal lines parallel to the pleural line, which are equidistant from each other. So this is A1, first A line, this is second A line. So these are the A lines. A lines are seen when the ultrasonic waves actually reverberate horizontally. See, these are the ultrasonic waves coming, and in case this is a pleura. Right. So, what do you mean that when the ultrasonic waves comes, first it hits the skin, right? Soft tissues, then it comes and hits the pleural line. And see, it is coming and it is reflecting back to the transducer. This causes horizontal reverberation of the pleura. This pleura moves in a horizontal way when the multiple ultrasonic waves come, hit, and go back. So when the second ultrasonic wave comes, again it reflects back and it takes some energy, some signals back to the transducer. So when multiple ultrasonic waves come, they hit, it causes horizontal reverberation and it causes multiple A lines, which are parallel to each other. They have multiple reflections, which are called as A lines. So sometimes it is also seen that it looks like a bamboo spine appearance, right? This is pleura, this is another one line, then the second A lines. It sometimes looks like a bamboo appearance. These are the A lines. This is A lines means the lung is good aerated, but normally it is seen in a normal healthy lung. But if there is more A lines with absent lung sliding, it indicates pneumothorax. So look, this is a bamboo-like appearance. This is a pleural line, and these are the A lines. It indicates that there is air. It could be physiological in a healthy lung or pathological. As I told you, it can be seen in pneumothorax. So this is the pleural line and these are A lines. This is a one A line. This is a second A line. Right? One A line, second A line, third A line. They are equidistant from each other. The another artifact which we are seeing is a B line. I'm not very happy with the B line. So look at this picture. This is the pleural line and this is a B line is a vertical echogenic line which is starting from the pleural line and goes to the bottom of the screen. These are laser-like. These are hypogenic laser-like vertical lines from the pleural line and goes down, and they also move with the lung sliding, or they also move with the respiratory movements. And when you have B lines, lot of B lines, they erase the A lines. Actually, how are they formed? This B lines were actually first demonstrated by Ziskin and his colleagues in 1982. And this is actually generated by the reflection of the ultrasonic waves when there is fluid in the interstitial space or in the intralobular or the intralobular septae, when there is lot of fluids. So when the ultrasonic waves, I'll show you. See, this is the interstitium. This, and when the ultrasonic waves come and they hit, they reach the skin, subcutaneous tissue, and these are the ribs, these are the intercostal space, and this green line is a pleura. So when it hits the pleura, and when there is lot of fluid in the intralobular or the intralobular spaces or in the interstitial spaces, there are fluid bubbles. So what happened? This ultrasonic waves get trapped into these bubbles, and these causes some vertical reverberation, vertical movements, and this vertical movement will cause some artifacts which are called as B lines. So B lines are seen in pulmonary edema. When you have B lines, means there is some interstitial disease. You don't have very good aeration of the lung, and there is some interstitial disease involved. Like there can be some pulmonary edema, or there is some congestive heart failure, or there's some pneumonia or RDS. You can see B lines in TTNBs. Sometimes B lines can be seen in the initial few hours of life in a normal neonate. As we know, there is fluid in the lungs. Initially, the lungs are wet. So it takes some time for the transition to happen. So initially 48 to 72 hours, you might see the B lines. So look at this. This is a pleural line. Pleural sliding is good. And these are the vertical laser-like lines starting from the pleural line and going to the bottom. And see, we are not able to see A lines here because the B lines are erasing the A lines, and the B lines are moving with the respiration. So this is how B lines look. So there are different severity of B lines. More the B lines, the more severe is the fluid in the lungs. So we have simple B lines, we have confluent B lines, and we have compact B lines. What happens when there are less than 3 B lines in the intercostal space, in one intercostal space, and they're not erasing the A lines, they're called as simple B lines. And if the entire intercostal space, I'll show you the videos, is filled with the B lines filled with the fluid, then it is called as confluent B lines. If such confluent B lines are seen in 3 intercostal spaces, it is called as AIS pattern. Right. And another terminology is compact B lines, where the acoustic shadows of the intercostal spaces are also disappeared. Then they are called as compact B lines. If you see such compact B lines in all the regions of the lung, it is called as whiteout lung. Look at these videos. You will understand better by looking at this video. So this is the first video. You have just 1 or 2 B lines in the intercostal space. So this is a B lines, simple B lines, and see, you're not erasing the A lines. You can still see the A lines. These are called as simple B lines. Right. The another video is, see, there are multiple B lines in one intercostal space. This is called as confluent B lines. So when such kind of confluent B lines is seen in 1, 2, 3 intercostal spaces. So this pattern is called as AIS pattern. So another picture is of compact B lines. Look at this fourth picture. So the acoustic shadow, this black thing is the acoustic shadow. When this disappears, then it is called as compact B lines. So this is a video of compact B lines. So another terminology is comet lines. Comet tails are similar to the B lines. They start from the pleural line, but they are just short path. They are also reverberation artifacts caused due to maybe a little of fluid in the interstitial space, but they fade away. They do not reach to the bottom of the ultrasound image. So these are called as cometals. I'll show you like this. These are the B lines which are starting from the pleural line coming to the bottom, but these small vertical lines, I hope you can appreciate. These are the comet tails. They also move with the respiration, but they do not reach to the bottom of the screen. So they are not of much significance. So then coming next to the M mode. So once you have learnt pleural line, you have learnt the pleural sliding, how the lung sliding is seen. Then we have seen what are the A lines. We have seen what are the B lines. We have seen the severity of B lines. And we have seen what are the comet tails. Now coming to the M mode. M mode is usually seen for the motion, moving objects. Like M mode sign helps in differentiating the normal lung appearance. That is a normal lung, which is usually we call is at when we go into the profiles, there are different profiles in lung ultrasound, which we might cover in our extensive classes, extensive lung ultrasound classes. So a normal lung usually has a profile. So M mode actually helps us to differentiate between A profile and a A prime profile. A profile is seen in a normal lung and A prime profile is seen in a pneumothorax. So when you put a M mode, you can see a sandy beach sign, or it is also called as seashore sign. I'll show you the pictures. And this sign of that is a sandy beach sign is seen in a normal lung. So show you the picture. Right. So this is a M mode, which is showing us a seashore sign. See, this is an intercostal space. I'll show you where to actually put the M mode. Yeah. So see, this is a one rib, this is another rib. So you have to put M mode here in between the two ribs in the intercostal space. Don't put a M mode on the rib. You need to put the M mode. You have a knob in your machine which is called as M mode to see the motion moving object. So you have to put a M mode here. Right. So once you have put an M mode in the intercostal space, so this is the picture you get. I'll show you what it is. This horizontal lines are the soft tissues, the superficial tissues, that is the chest wall. What does it include? It includes skin, subcutaneous tissue, and the pectoralis muscle. Right. So this picture is seen as an ocean or it is seen as a sea. So these are the horizontal lines. These are the motionless area, that is a superficial tissues. This horizontal echogenic line is formed by the pleura. Right. So this is the pleural line, the horizontal line, which is separating the superficial area from the lower area. So this area, which it is again an artifact, but it indicates that this is a lung parenchyma. So this is seen as a sandy appearance, which is called as, so that is why it is called as sandy beach appearance, or this is a sea and this is a shore. Right. So you can call this M mode picture as a sandy beach appearance or seashore sign. The seashore sign changes or disappears and you get a stratoscopic or a barcode sign where the line below the pleura, the area below the pleura also is seen as a horizontal lines. Right. So this is seen in pneumothorax where the pleural sliding is absent. Right. Again, as I told you, we have certain, after doing everything, after learning so much, still there is some limitations. This lung ultrasound is an operator dependent. The scanning skill and the correct interpretation of the image can be completed by the operators who have been given formal training for a period of time. Like we are training our doctors for 3 months in lung ultrasound. So that they get the necessary knowledge and skill. So, for diagnosing pathologies like pleural effusion, pulmonary consolidation, alveolar interstitial syndrome, it usually takes around 6 to 8 weeks to confidently diagnose the lung pathologies and actually look into all the signs of pleural effusion, different types of consolidations and diagnosing RDS and all. So again, diagnosis depends on the patient also. As the fat layer of the obese children are relatively thick, sometimes it gets difficult to obtain the good images. If the baby is fat or obese, you have to decrease the frequency of your probe. If the baby is thin, you can increase the frequency. Sometimes the subcutaneous emphysema also hinders the conduction of sound waves, and ultrasound is not very well used in the diagnosis of emphysemas. So, the take home message of today's session is that no artifact will actually give you the exact diagnosis and pathology of the disease in the lung. Whenever you are doing a scan, just don't depend on the lung ultrasound findings or lung ultrasound images. You have to know what is the current complaint of the baby, what is the clinical condition, what is the medical history, what is the physical examination, and what is the course of the baby in your NICU, what are the biochemistry findings, what is the sepsis screens. You have to correlate your ultrasound in images with all these things, clinical findings, and then you will have to interpret. So the advantage is that you yourself are doing it. So the correlation can be in a better way. And so, whenever you want to make a conclusion and you're planning to take some change to management in your baby, you should first ask whether the severity of the patient's clinical condition is actually correlating with with your ultrasound findings. Then you make some decision. Then you come to a diagnosis, and then you can plan your management accordingly. So thank you. This was all for the basics of lung ultrasound views. So thanks for the patient hearing. And any queries we can discuss. Right, Dr. Kunal? Is the session open for questions?
Yeah, thank you so much, ma'am. It was a wonderful session. Uh, there is a question. Can you differentiate between pneumonia and RDS?
Yes, definitely. There are different patterns of artifacts in pneumonia and RDS. Okay, if you ask me one point to differentiate, you have a shred sign in pneumonia, and whenever you have some pathology, pneumonia will not be a homogeneous. It is not a homogeneous disease. Pneumonia can be in one area of your lung, or maybe on right side of a lung and not on the left side, or maybe in a single region you might have a pneumonia patch or consolidation. But RDS is a homogeneous disease. You will have the sub pleural consolidation, so more uniform kind of thing, and they're more of atelectasis, and it is a uniform pathology, and RDS doesn't have a shred sign. Right, if you know what the shred sign is, it is very pathognomic of pneumonia. So yes, definitely, lung ultrasound helps us to very strongly differentiate between RDS and pneumonias.
TTN. There is question by Dr. Kamal Parikh, the difference between TTN and RDS.
Yeah, actually, this was a basic lung ultrasound session, but yes, we can clear your queries. Like, see, again, one differentiate point is the RDS is a homogeneous disease. TTNB is not a homogeneous disease. TTNB, the main physiology or pathology is that there is a fluid in the lung. It is called as a wet lung, and when the baby is in a supine position, the fluid settles down, so you won't get those kind of B lines throughout your lung. The upper area will be more of a profile with good A lines, and the lower region will have a B profile. So there is a, if you have read, there is a double lung point, which is a demarcation between aerated lung and non-aerated lungs. Yes, in certain severe cases of TTNB, they might look like RDS, but again, the second important differentiating feature is that in RDS, you will have subpleural consolidations, and in TTNB, you do not have subpleural consolidations. This again strongly differentiates TTNB from RDS.
Uh, Thank you, Dr. Kamal Parikh, for the questions, and we'll be continuing with our lung ultrasound series And further, every month, second Wednesday, we'll have our focus series in which we'll be taking the lung ultrasound, this thing. So I think there are no more questions are there. Vishal, Dr. Vishal, do you have anything to add?
No, no, that's fine. I think it was a nice session. Actually, I was stuck in the NICU, but it was nice session, Dr. Surjit. And I think there's a one message from my side. I think specifically who are trying to start the lung ultrasound that the main purpose is not always the pneumothorax because always people are used to rule out the pneumothorax. But basically, the when I started my lung ultrasound, I did because to differentiate TTN versus RD, specifically those baby who are coming to your NICU between 30 to 36 weeks. It is difficult to differentiate the RDS and TTN by X-ray, and it is always dilemma that should we give the surfender or not. So basically, you can start begin with that things, and I think lung ultrasound is easiest ultrasound in the world because there is no any that much expertise required to to assess the organ. So I think for the hemodynamics, I would suggest a lung ultrasound and USG head is the first thing you need to learn, and follow by the echo and everything.
It's definitely, Dr. Vishal. It is easier than echo and
Echo and
cranial ultrasound and
and
all. It is
we are
easier.
encountered the 90% pathology on lung rather than the heart. If you
Yes, yes,
see that, yeah.
definitely.
So basically, that is a mandatory thing if somebody used to do the ultrasound who has a echo machine
Yes, you can actually diagnose so many pathologies, and I
pathology.
think we all agree that respiratory pathologies are more common in our NICUs than cardiac.
Cardiac
So it actually helps in the management, and lung ultrasound seems to be very simple, but there is lot and lot to learn in
lung.
lung ultrasound also. Yeah,
Yeah.
definitely it
Thank you.
is easy, Dr.
Yeah.
Vishal.
Yeah.
Yeah.
Thank you.
Thank you, Dr. Vishal, Dr. Kunal,
Thank you
and
so much, ma'am.
Elena
It was a
Gujarat.
Yeah, thank you so much, ma'am. It was a wonderful presentation, and this is one of the first topic in our lung ultrasound series, and we'll be continuing with the same series on every Wednesday, second Wednesday of every month.
Right.
Thank you so much, ma'am.
Thank
I
you.
think there
Thank
are
you.
no further questions are there. Thank you, Vishal, for joining also. Shriyashi, over to you.
Thank you, sir. Thank you, sir. Thank you, ma'am. Thank you so much, everyone, for giving us the opportunity to host the session today. So, with everyone's permission, I'm concluding the session over here for today. Thank you. Have a nice
Thank
day
you.
to all of you.
Thank you. Thank you.
Thank you so much. Thank
Bye.
you, ClearNet, for the seamless experience.
Thank you,
Bye.
sir.
Thank you.
Bye, Dr. Surjit. Bye,
Bye. Bye,
Kunal.
Dr.